Hey guys, thanks for having me. My name is Robert Plemmel. I'm a DPT with Athletico in Sioux Falls. I've been specializing in temporomandibular dysfunction for about the last year now. This is a physical therapy approach to temporomandibular dysfunction. So a little bit about myself. I grew up in Detroit Lakes, Minnesota. Got my undergraduate degree in biology from Minnesota State University Moorhead, the Dragons. Then I studied business at University of New Mexico in Albuquerque. And then finally in 2018, got my DPT from University of North Dakota. Um, Up at the top right, that's a picture of me and my wife. And then our newest addition to the family, Raina, who was born in February. Got into TMD. My wife is actually a dental assistant, so they were looking for people to send referrals to, and I figured TMD would be a good specialty, and it kind of just stuck. So a little bit about TMD. It's actually a lot more common than most people think. It is the second most common musculoskeletal pain that affects about 33% of the population. Oddly enough, though, only 3 to 7% of people actually seek treatment. Which is something that we need to do a better job at. And I think a lot of it is just people not knowing where you go. Do you see a chiropractor? Do you see a dentist? Do you see an MD? So there's a lot of confusion surrounding this as far as to who treats it. In the US, there's over 3 million cases per year, and we usually see it manifest in younger adults. I'd say the youngest patients I typically see are 15, 16, around there. And then we see it all the way up into geriatric patients as well. I think the etiology is different in those populations, but we'll get into that as we progress. TMD affects women a lot more than it does men. In a study they did, they looked at 18% of women were affected by TMD, ages 25 to 44, versus only 10% in men. Talked about the etiology being very, very different. So there's a lot of things that can cause temporomandibular dysfunction, varying from physical trauma all the way to emotional stress. I'd say trauma is more of a rare case that we see. Usually we see these kind of chronic type conditions. It's a lifestyle type thing, but we do see some trauma every now and then. But I won't bore you guys too much with anatomy. It's very, very important. I put these two muscle groups in just to begin with because they are the most probably important as far as what we see. So temporalis and masseter, those are your clenching muscles, the ones that bite down. So oftentimes you get people come in and they'll talk about, well, I've got these headaches on the side of my head. I just want you guys to appreciate where the temporalis muscle sits. So if that muscle is in contraction all the time, we're starting to cut off some blood flow to that area, and that can cause some of those headache type pains that people feel. Masseter, obviously down here, that's one of your main closers of your jaw. We palpate through that, and people often talk about trigger points that kind of light up those areas in their masseter. Tons and tons of force that these muscles do. Obviously, it's your main biting force, so they're very, very strong muscles. But they're not designed to be used all day long. So what I tell people is you're normally supposed to have some space between your teeth. Your teeth should never be touching throughout the day unless you're chewing. When they are, these muscles will go into spasm because they're constantly fighting gravity. So I kind of give my patients a little bit of a way to remember this is I tell them if you carry around a 5-gallon bucket of water all day, your arm would get sore, right? So the same thing happens in your jaw. If these muscles are fighting gravity constantly throughout the day, you're going to get some pain, and it's not going to be comfortable. The next muscle group that we're going to talk about is just medial and lateral pterygoid. So these muscle groups are very important too. They're involved in elevation, protrusion when they're bilateral, a little bit of rotation, kind of like grinding as you're going back and forth with your food, and lateral deviation too. So on the contralateral side. So oftentimes we can see when we have people deviate their jaw, we'll kind of find differences in this stuff. Or resisted motion testing, we can kind of find some tight lateral pterygoids that way too. The other thing that's important about pterygoids is the relationship to the disc. And we'll get into that, but the lateral pterygoid actually attaches to the anterior portion of the disc. Important muscle groups. They're kind of hard to get to, so you got to really trust your manual muscle testing to be able to pick those out. Next group of muscle tissues that we're going to worry about are the mandibular depressors. These are going to be your hyoid muscles and your platysma. There's no muscle group like temporalis and master that's super, super strong that opens your jaw. A lot of it's done through gravity, but these muscles will open your jaw. So oftentimes when we find these tight temporalis and tight masters, we'll try to activate these muscles to try to turn some of those off. So good thing to assess these muscles as well. You can find some weaknesses here with resisted opening. Um, and obviously changes the head position when they're doing these things because it's a little bit more of a difficult muscle group. Other super important anatomy is in the cervical spine with TMD. Suboccipitals, we see a lot of forward head posture, a lot of tight upper traps, a lot of deep neck flexors. I would say it's very, very common to have neck pain and TMD at the same time. It's pretty rare that we see just strictly unilateral TMD. More than likely, it's kind of a global issue. A lot of postural deficits in these people. One of the things I want to talk about is just so the deep neck flexors. I'm sure you guys at some point will start doing deep neck flexor tests. We might do it in this lecture here. We find a lot of weakness in this, and we find a lot of tight sternocleidomastoid. When those muscles are weak, sternocleidomastoid tends to pick up the slack and becomes a dominant neck flexor, and it's just not built to do that. In addition to that, with that forward head posture, we get a lot of tightness through these muscle groups here. So we'll talk about people with posterior chain headaches that kind of wrap from the back and go to the front. Oftentimes, these are kind of the culprit. We can do a little suboccipital release, and if that kind of takes care of it, then we know we're kind of on the right track. So the other thing to appreciate here is the disc anatomy. So this is a kind of a close-up idea of what we're looking at here. So this is the socket that your temporomandibular joint fits into. So when you open your mouth, it should roll around here and then glide forward. So it really follows that condyle. That disc is set in between there, just to obviously stop from bone on bone. So one of the things to appreciate about this disc is obviously the muscles that we talked about, so the pterygoid muscles attaching to that disc, very, very important. And the other thing about the disc is just that the disc itself has very little innervation in it, so there's not a lot of pain. When people are just normally riding on that disc, you shouldn't have pain in the temporomandibular joint. What happens is sometimes this disc will slip forward, and this retrodiscal tissue that sits back here is highly innervated, so super, super painful. So if this disc is up here and we're rolling on this all the time, that can be very, very painful. The other thing to appreciate is the auditory meatus sits right here. So appreciate the relationship between the two. We'll get people that come in with temporomandibular dysfunction and ear problems as well. So they'll talk about tinnitus. Temporomandibular tinnitus is another condition that's associated with this or fullness feeling in the ear. They'll talk about, well, my jaw doesn't hurt, but I have all this pain in my ear. So important to kind of weed some of that stuff out. All right, we talked about trapezius a little bit. One of the things we see, we talked about posturally, people will come in and they'll have really, really tight upper traps and weak scapular depressors. They're kind of that rounded forward computer posture. So just kind of appreciating here some of the some of the referral pain patterns for the upper trapezius that they can kind of sit up through here, up through here. Up through here is a super common one that we see people talk about, like this interscapular pain. Most often than not, that's a referral pain pattern from upper cervical region. So we always look at that stuff. So just appreciate that where the patient's telling you they have pain may not be the cause of their actual pain. So with these scapular depressors, we just see a lot of weakness and a lot of increased space between there. So posturally, TMD fits posture very, very well. So one of the first things I do when a patient comes in is just observation. And you guys are all really good at this and doing your evals anyway, I'm sure. But just looking at how they're sitting there talking to you can tell you a lot about the patient. So posture, we talked about forward head, kind of kyphotic, hiking of the upper traps. And then we talked about that posterior chain weakness. and the upper trap dominance. I'll see patients that come in and they're talking to me, and the entire time they're just clenching their jaw. Um, so those are things to look for. Obviously, if you see them clenching their jaw, it's pretty much a slam dunk. You can change their life pretty quick if you get them to stop doing that. So, and then jaw malposition, we see that every now and then. People, just like in a back pain patient, talk about those lateral deviations. People will move away from their pain. So you'll see them kind of with their jaw kicked off to one side to kind of give that joint some space and some rest. And then we see a lot of anxiety and restlessness when people come in, and that could be just some underlying psych type stuff, or people just didn't know where to go for so long to get this stuff. So there's like, I've been to 4 different people, I've seen an ENT, and they're just kind of sick of this, and it can kind of be draining on them. One of the other things I've seen, probably to a lesser extent, is some people have tics, nervous tics. I had a patient a couple weeks ago that came in, and every time she would talk, every time she'd open her mouth to talk, she would kick her jaw off to the right. So she had just tons of left-sided pain, mostly kind of ear pain, but her lateral pterygoid was just on fire from all day, just kicking off to the right. So we worked a lot on kind of retraining her for that, and then obviously made recommendations for psych based off that too. All right, so before we go any farther, I think one of my biggest my biggest pet peeves is people come in and, oh, I've got TMJ. Well, yeah, I've got 2 as well. So it's TMD. TMJ is the name for the joint. Temporomandibular dysfunction is a more accurate description of what's going on. Probably bugs me just about as much as it bugs me when people say they have sciatica. Anyway, we want to get a good subjective impression of what the patient's coming in for. Pretty much your typical stuff that you'd ask for any patient coming in. We want to know when it started. Do you see any correlations with anything that happened? Psychological stress, I'll oftentimes ask patients about that. You have to be kind of tactful with how you do that. But oftentimes we'll find, well, my mom died around the same time that this started, or I was diagnosed with cancer around the same time that this thing started. Things like that are kind of good triggers to kind of lead you down the psychological stress realm. And then we go in a little bit different direction. I always ask progression throughout the day. Super important. If the patient tells me, hey, I wake up in the morning and my jaw is so sore, that points me in the direction that there's doing something at night, obviously, that's causing some of this, or it's a disc derangement, and that fluid stasis in their jaw is causing a lot of their issues. So, but if they're telling me like, hey, my jaw's fine in the morning, as the day goes on, it gets worse and worse and worse, more often than not, they're probably a clenching problem or a use issue. So when we talked about these associated headaches, so headaches in the back of the head, we look at suboccipitals, things like that, the ones that wrap towards the front. People talk about the headaches near that temporal region. Then once again, we're kind of looking at clenchers. But yeah, headaches play a huge role in this too. It's pretty common to see them work in conjunction with each other. And then we always talk about what makes your pain better, what makes your pain worse. Some people have some interesting responses to those questions. But yeah, it's really important to know, like, hey, if I open my mouth, it's worse than closing it, or if I close it, it's worse than opening it. Usually that terminal opening, we kind of think more, if that's the most painful thing, we kind of think more disc related, whereas closing, they're doing an active contraction of temporalis and master, then we think of more of muscle and mastication dysfunction. Like I talked about in the beginning, this history of trauma, I don't see a ton of trauma really. It's out there, but I guess I don't see a ton of it in my practice setting. If they're to the point where they'd needed some kind of orthopedic surgery or something, they're seeing an oral surgeon for that. So, but I will see them after. I mean, we've seen some arthrocentesis and jaw fracture type patients that kind of come back in after the fact, which is some tight musculature, and so those are things we work on. But usually acute type trauma stuff, I don't see a ton of. Then we always want to look at systemic signs and symptoms, lymphatic involvement, trigeminal neuralgia, all those things. So there's a lot of lymphatic tissues in your neck. people talk about when they kind of come in and they get like this ear pain and stuff. So we really have to weed some of that out. So we have to be really, really good at differential diagnosis and knowing what we can treat and what we can't. Um, and obviously trigeminal neuralgia, you should be able to see that when they come in. They'll talk about really hot shooting type pain. But yeah, it's super important, especially in females. We've had a couple of patients who had some cardiac issues that will refer pain to their jaw. So always make sure we're looking at that stuff too. All right, so our objective testing. So we do a lot of cervical motion testing. I should preface this with I'm kind of a McKenzie guy, so I like repeated motion type testing to see if we can put some of the healing back on the patient to let them feel in control a little bit. So always do cervical motion testing. I'm looking for replication of symptoms in their jaw or where they're having pain. I always break up, differentiate between upper cervical spine. So I'll have them look down and then I'll test their upper cervical spine that way. Because oftentimes, if you can do a gross cervical spine objective testing, but and they may test totally fine, but as soon as you put them into kind of upper cervical motion testing, they'll be way different. So it's always important to look at that stuff. I always look for directional preference too. If somebody tells me, hey, I turn my head to the left and I get an increase in my jaw pain on the right, oftentimes I'll start with working into repeated extension, have them turn to the left again if they feel better. Then we know that we've put the patient in control a little bit. Whether or not something physically is changing because of that or not, who knows? But it gives the patient some kind of feeling that they can control some of their own symptoms too. That is the most important thing with this, is letting them know that they've got the tools to treat this. All right, and then our palpation skills come in really handy with this stuff. So we're palpating temporalis, masseter, pretty much all those structures we talked about before. We can do a little internal palpation of pterygoids. They're kind of hard to get to, and they're usually painful to palpate anyway. But sometimes you'll get more pain with palpation to one of them than the other one. I look a lot at sternocleidomastoid insertion. Usually we get some kind of ipsilateral type sternocleidomastoid stuff going on too. And then suboccipitals, once again, kind of working through those. Give a little manual traction if people talk about they've got like these posterior chain headaches. And oftentimes you'll see it go away, and it kind of guides you into the idea that there might be some suboccipital stuff going on. So just a little bit on normative data for opening. This can kind of vary a little bit, but this is what is generally accepted as far as normative data. So normal is about 35 to 40 millimeters of opening. A gross test for that is about 3 fingers stacked on top of each other. If they can get about 3 fingers, then they're pretty good. 10 to 12 millimeters of lateral deviation is normal. So you will see differences in deviation with the discogenic type issue. So if somebody's got, for instance, a right temporomandibular joint problem, they won't be able to deviate to the left. And the reason why is they have to get that anterior glide, and they lose that if they've got a disc dislocation. Protrusion is oftentimes a good one to look at too. So 3 to 6 millimeters is pretty normal for protrusion. And we'll see kind of pain at end range if people have more of a discogenic type pain than a muscle of mastication pain. So once again, in our objective, we're definitely looking at active range of motion and passive range of motion. Passive range of motion probably to a lesser extent than active range of motion is very important and can kind of really guide you on what's going on. So opening patterns are huge. So just looking at, so let's talk about the C curve first. So this guy in picture A has what's called a C curve. So he is deviating to his left side. So what that tells me is his left temporomandibular joint, there's something going on there where he doesn't anterior translate. So there's no movement forward on that side, so they kick off to that side. Usually painful at end range. Then we've got an S curve, and what that does is it usually starts off, they'll open, and they'll kick off to one side and then kick off to another side. That's most of the time a muscle of mastication dysfunction, so you're looking more muscles. So remember, C curve guides you to a joint, S curve guides you to muscles. Joint sounds. Sometimes I'll get patients that come in that just say, hey, my jaw clicks all the time. What I always tell those people is if it's not painful, we usually don't worry about it. So kind of let the sleeping dog lie. You can get a disc dislocation with reduction, meaning it goes back into place. That can be that clicking sometimes. It can never be painful, and life can go on, and everybody's hunky dory. Um, so yeah, usually joint sounds we don't worry about too much unless they're painful. Um, and then last, we always look at joint mobility. So how well I can internally kind of mobilize that joint. So losses of anterior translation, things like that. So really, inferior and anterior glides are probably the most important. We kind of do some rolling glides too, but just to feel around for that stuff. But your active range of motion can tell you a whole heck of a lot about what's going on. And then special testing. So fulcrum biting testing. I think we'll do a video on some of these tests too. Um, Fulcrum biting testing can differentiate between muscles or joints. So if people tell me, hey, I've got the most pain when I'm closing down, sometimes what I'll do is I'll just have them bite down teeth to teeth, and they'll give me a rating of their pain on a scale from 0 to 10, and then I'll put either like a popsicle stick or a tongue depressor in and have them bite down on that to kind of give the joint a little bit of space. And then I ask them the same question. If there's less pain with the tongue depressor, we're thinking more joint. If there's more pain with the tongue depressor, then we're thinking more muscles. So, or the same pain, I guess, too. Joint compression, you can manually compress that joint too, just by coming on the off of the mandible and kind of manually compressing up. It's not going to be comfortable for the patient, so I don't use that one quite as much. Manual muscle testing is huge for the temporomandibular joint. Just kind of seeing what those muscles are doing. Remember we talked about lateral pterygoid. You can have them deviate to the, let's say they'll deviate to the left, and you resist that motion, and it's super super painful. Then we're kind of thinking right lateral pterygoid. This is a classification for muscle or for temporomandibular dysfunction. So this is the Harris classification. I believe this is a therapist that created this. So we've got our group 1. These are your clenchers. This is the masticatory muscle dysfunction. So we've got 1A, so those people open normally, but they just have painful opening. And 1B, these are the people with limited opening, so those muscles are really tight. Oftentimes we'll see bilateral involvement with this stuff. Not always, but most of the time we'll see a bilateral involvement. And then we've got our group 2, which are the disc displacements. So we've got disc displacement with reduction. That's the click open, click close. So that disc reduces back into place. 2B, so we've got disc displacement without reduction, limited opening. So that's the clicking. The click is absent with this one, so they don't reduce. So there's no click, but they have limited opening. You'll see a C curve with these 9 times out of 10. And then we have disc displacements without reduction with normal opening. Those are the people that have displaced for a long period of time, remodeled that disc tissue, and have normal opening because of it now. So that's typically that category. Usually I try not to use the words disc displacement with my patients. I don't think it's helpful for them. You can say the disc is a little irritated, things like that. But often these catastrophizing words that we use can really kind of change how the patient perceives their condition. They're already coming in telling you they got TMJ, and so anything we can do to kind of pull them off of that, I think is helpful sometimes. And words like disc displacement are not helpful for them. It is important to educate your patients though on what kind of conditions are going on and how the whole system works. I think that's really important for them, and how they can treat it is important too. So we talked about differential diagnosis being super important. So things we're looking for here: trigeminal neuralgia. Ear infections are huge. So we see some ear infections that'll kind of manifest and seem a lot like TMD. We get some vascular and cardiac stuff. Females, oftentimes, not oftentimes, but every so often will refer pain to their jaw when they're having some cardiac issues. We've seen a couple of these in the clinic, so it does happen. So that's when you look for your other symptoms too, like you're talking about shortness of breath, you're talking about lower extremity swelling, chest pain, back pain, stomach pain, pain in the arms, things like that. So really doing a good job differential diagnosis there. And if you don't feel comfortable, just send them back. it's not worth treating them for that long and then being wrong about it. So space occupied lesions, we get some cancers, some oral cancers that'll show up as some kind of jaw pain. Oftentimes I'll see these as people talk about, like I've got pain kind of in my maxilla, like it almost seems like it's a masseter type pain, but it's too far forward to be a masseter. And it'll actually be like a cancer or a space occupying lesion kind of in their mandible or maxilla. So really trust your palpation skills when you're doing this. If it's not on a muscle, if it's not on a joint, then it's probably not for you. I put this in here as a little disclaimer. So like I said, we see less males than we do females. Or I'm sorry, yeah, we see less males than we do females with temporomandibular dysfunction. A lot of them, not a lot of the males, but some of the males you'll see have some psych disorders. There's a correlation between schizophrenia in males and temporomandibular dysfunction. Nobody's sure why, but there is a correlation between those things. So you want to talk about those. I had a patient one time who told me that the only way he could get his jaw pain to go away was to cut a toothpick in half and stick it between his teeth and then put oatmeal in his front lip. And so obviously we sent him back because he was not a physical manifestation of pain. But yeah, those are things that you need to look for. And then obviously persistent type pain plays a huge role in this. A lot of people have been dealing with this for a long time, 6+ months, years in some cases. So when you move into that chronic pain type cycle, you're fighting a whole new battle. So you need to kind of weed those things out too. So goals. Our goals are first and foremost, we need to address any psychological factors that are playing a role into this, because you can do everything physically in the world and get nowhere if you don't address that. So if you're not comfortable addressing psych factors and getting people to see who they need to see, then TMD might be a difficult specialty. As far as where we're at, restoring normal range of motion, first and foremost, is super, super important. Let's get that range of motion back, get these people eating normalized diets again. One of the first things that a dentist or a doctor will do when a patient comes in and tells them, well, hey, my jaw hurts, they'll say, well, hey, soft foods, no chewing gum. I kind of don't agree with that in a lot of cases. And part of the rationale for that is, let's think about a disc dislocation, for instance. So we need that disc to start remodeling and to being kind of more of a normalized disc, because the chances of you getting that disc back in place are slim to none. Usually it doesn't happen. If that disc is dislocated and it's displaced anteriorly and it's not reducing, it's probably not going back. So the quicker you can get these people to kind of wear that retrodiscal tissue down to kind of remodel a normal disc, I would say the better. So not to say to go against what their dentist is telling them, but I want patients to kind of return to a normalized diet faster than I think their dentist would like. So keeping that in mind, chewing gum I don't think is necessarily a bad thing, especially for clenchers, people that clench consistently. At least it gives them something to do that's not biting down on their teeth all day. In addition to that, we want to eliminate these tension headaches. Usually if we get people to stop clenching, those temporal headaches will go away. And then kind of restore some postural stuff, and usually those posterior chain headaches kind of alleviate that way. And then finally, we want to prevent future dysfunction. I do a lot of scapular training on patients, scapular depression more so than elevation. I blame the upper traps for a lot of stuff. But anyway, we often see just weakness. And I mean, just like any other part of the body that you're treating, you want to find the deficit and treat it. And it just so happens that a lot of the deficit that I find is kind of weakness in middle and lower traps, some of your scapular retractors and depressors. And people are just so upper trap dominant. They're just using their upper traps to do everything. So preventing future dysfunction means we kind of address those factors too, so they don't end up back in the clinic. All right. So treatment. So treatment is very individualized for patients. Oftentimes what I'll do is I call it the sticker method. So if I find somebody that's in there and they're clenching all the time, I'll give them the sticker method, and it kind of sounds cheesy, but it's usually pretty effective. So basically, what you do, we educate patients that your teeth should never touch unless you're chewing, um, and so we give them these stickers, and we'll have patients put these stickers all over their house in places that they normally look. So back of their cell phone, rearview mirror in their car, their computer screen, and every time they see one of these stickers, they have to ask themselves, "Are my teeth touching?" So it's kind of a biofeedback tool that we use that's usually pretty effective. The other tool we give them is this exercise called clucking opening. Arguably, probably one of the best exercises that you can give anybody with TMD. If you're ever in a bind, have no idea what to do, give them clucking opening, and chances are they'll probably do at least a little better. So I'll do a video on that one too. But basically, what it is, you put your tongue on the roof of your mouth and you open and close repeatedly. I tell people 10 times every hour. It does two things. It helps restore that normal roll and glide that the temporomandibular joint should do. It also keeps people from clenching throughout the day. If they're doing something active with their jaw, they can't clench when they're doing that. We do a lot of neuro re-ed. So we talked about those deep neck flexors, scapular retractors, scapular depressors, and then using some kind of reciprocal inhibition for those hyoid muscles to turn off temporalis and masseter. So kind of resisted opening type exercises against a stress ball. And then restoring normal muscle tone, so stretching. So we'll see limitations in cervical motions. So we always make sure we kind of address those. So we talked about sternocleidomastoid. I find that we stretch sternocleidomastoid quite a bit. And then obviously in conjunction with training those deep neck flexors is important. So if you're going to stretch a muscle, you should probably find the one that should be doing its job and work that one. Modalities. So I kind of go back and forth sometimes on some of these modalities. They're important, don't get me wrong, but they shouldn't be the main course of your treatment unless it's a super acute, like, hey, I went to the dentist yesterday, can't open my jaw now. Usually I see kind of you talk about, they're in that acute inflammatory stage. So iontophoresis with some dexamethasone works really, really well in those patients. Treat them twice, you'll never see them again. They do really, really well. This is an iontophoresis patch. This is not what we use in the clinic. We have kind of a specialized one. Looks kind of like a starfish, so it wraps around your ear. I'll show a video of doing that too. I don't use ultrasound that much. I just don't find it that helpful unless there's a patient that requests it. Obviously, placebo effect is really big when patients request a treatment or they say, hey, I've had ultrasound before and it worked really, really well. You're going to do ultrasound, right? But I think from a physical standpoint, I don't think you're doing a heck of a lot. The good news is the temporomandibular joint is really close to the surface of the skin, so you can kind of get to it with some of that stuff. But I just find your time is probably better spent in other places. But for some patients, I definitely will use that. Get some buy-in a little bit. It feels good. So we use some TENS on the jaw too. It's a little more awkward. You got to find some smaller pads to do it with, but usually we do one pad kind of by the ear, and then we do one pad on the masseter, and then two kind of in upper traps. So we kind of cross them. So some interferential current doing that stuff. I can show a video of that too. But really, your modalities, I always think of them kind of in the acute stages of what's going on, are probably the most important. Because I mean, if you're 6 weeks out on a disc dislocation, there's probably not a ton of inflammation going on anymore. So kind of pick your battles there. So. All right. Double check this. Okay. All right. So directional preference. I'm a big believer in directional preference. I know the studies say, like obviously the McKenzie stuff was we were reducing disc herniations, and we're finding that that's probably not what's happening now. It's a lot more complicated than that. But what we are doing is we're putting the emphasis back on the patient. We're giving them something that they can do that's going to alleviate their pain. Typically, it's extension, so really extension-based. So cervical retractions, I seem to help quite a bit. I push them hard. So 10 times every hour, I tell them to do these things. And then we're always rechecking those concordant signs when they're doing it in the clinic. So if the patient says, hey, I turn my head left and I get this right jaw pain that I usually have, I'll have them do 10 retractions, have them turn left again. And if they get a reduction in their pain, they kind of get some more buy-in that way too. Um, Once again, it puts the patient in control and allows for really small victories. Um, some people have been dealing with this stuff for years and years and years, had no idea where to go. And if you can give them even just a little bit to say like, hey, I can do this and I can alleviate some of my pain, I think that goes a long way for patients. So manual therapy. I always think of manual therapy as a temporary fix, because really I think I've seen some studies say even 30 minutes after they leave the clinic, what you did for your manual therapy, they're going to revert back. So especially with the jaw, because usually with the jaw, it's a repetitive motion type thing. Um, so anyway, we do use a lot of manual therapy in the clinic, but just remember why you're doing it. So joint mobilizations, cervical mobilizations. I know we're in this. Are you guys in Iowa? Maybe you're in Iowa. Maybe we could do manipulations in Iowa, but so we use a lot of manipulations too, not of the jaw, but of the cervical spine. Um, my thought process is you're decreasing muscle tone when you're doing those things. You're not relocating anything. It's just they get that click or that pop or that quick stretch, and it's a significant reduce in muscle tone. The picture here, I think this guy's doing some inferior glides. I usually do the internal inferior glides. I've done just with COVID stuff going on. I've started doing some of the external stuff, but you don't get as good of a mobilization that way. So obviously Dr. Wink is there, so we're going to rep some SayStim here. We use SayStim quite a bit through masters, and really temporalis. I think you kind of worry about some arterial structures that are up that high. But definitely use some SayStim on upper traps. We do a lot of that. Patients seem to respond really, really well to those types of things. I do a lot of a technique called AO shearing, which is, oh man, what is his name? Ernesto teaches a course on TMD. Dr. Ernesto, I think is his name. But it's basically a McKenzie distraction with cervical retraction. And patients really seem to respond well to that one. I'd say that's probably my go-to mobilization if I can't get anything else. But internal temporomandibular joint mobilizations can be kind of painful for the patient. So remember, discomfort is okay, but if we're really just making that patient super uncomfortable every time we do it, we kind of work to something else. So, all right, some just examples of what I do as far as I typically never say exercises because I think that number one, it gives us kind of a bad rep because people don't come to us to exercise; they come for intervention. So you always see me kind of talk about interventions. It puts the skill back into it rather than just exercising. So anyway, I do a lot of scapular retraction without elevation. So one of the tests I have people do is just have them pull into a row, and then I'll watch what their shoulders do. And most of the time, at the end of that, people's shoulders will hike up. So we just kind of train to keep them down, keep them back. I do a lot of prone cuff type stuff with scapular depression, three-way shoulder stuff. Once again, emphasis on scapular depression. I've even done some kind of more recently, some TMJ directional preference stuff. So people say, hey, when I open, it hurts, but if I go to the right, it doesn't hurt. So I'll have them go to the right 10 times, try opening again. Sometimes that works pretty well. Once again, putting it back onto the patient, giving them something that they can treat themselves with, I think is important. Thoracic spine mobility drills, just because of that kyphotic posture that we see a lot of these people in, we see a lot of thoracic spine tightness. So just some opening up drills, some pec stretching type things. And then deep neck flexor stretching, do a lot of that. Every now and then we'll see some kind of first rib dysfunction type stuff. So we'll do some belted stretching, things of that nature. And the most important thing that we can do is education. So it should be the focal point of your treatment with any patient is just education. I think our job is unique in that we really set patients up for success, giving them the tools that they need. So it's not that they come see us over and over and over and over again for the rest of their life. It's just that we can give them the tools they need, and they can go on with their life and kind of take care of themselves, which I think is super, super important. So really instilling confidence in them that they can do it, I think is really important too, to be able to self-manage their condition. So we just set them up for success for the long term. That was kind of a cool little cartoon too. All right. So if you guys haven't talked about persistent pain yet, by the way, I created this when I still called it chronic pain, and we call it persistent type pain now. I think is a better word when you're describing it to patients. So what is it? I think this is kind of the future of a lot of pain science is looking into this stuff. So really, it's just a miscommunication between the brain and the body. We talk about a hypersensitive system. I always use the example of an intruder to my patients. So if an intruder breaks into your house, your alarm system is supposed to go off. We know that. After that intruder leaves, the police come, everything's all good. You turn that alarm system off and you don't have pain anymore. A lot of times, persistent pain will start with an initial injury, but for some people, that alarm system just doesn't go back off. And then you end up in this persistent type pain cycle where you get pain, muscle tension, reduced circulation, muscle inflammation, reduced movement, and you just keep going, keep going, keep going, keep going. So it's important for us to kind of work into this system because up until now, we haven't had a lot of good ways of dealing with this. Obviously, we know opioids are not effective in treating persistent type pain. Most medications are not effective in doing this. I would classify a lot of my headache patients in kind of this category. Hey, I've tried every medication, nothing works. So really kind of working into that system. So, but just remember, it's not chronic, it's persistent. Just the verbiage that you talk to patients, especially with this condition, is very, very important. All right, this is kind of a nice little graph of explaining as far as what is hypersensitivity. So normally people have this pain threshold. So where there's everything below it is a twitch, a minor discomfort, an itch. But above that are things like a sting, an irritation, a pain. So those are the stages that we act in. Our body acts to actively get away from those things. So if you break your leg, you're probably not going to walk on your leg, right? It's a natural response and it's protective in a way. For people that have hypersensitivity, this pain threshold moves down. So what was before was a minor itch is now in your act stage. So you have to get away from it. You've constantly got to do something to get away from it. Or we see a lot of times, well, I don't want to move it because I think I'll hurt it even worse. Which, by the way, we know the science doesn't support that. I saw a study where we talked about our nociceptors are the strongest when a muscle is weak, and they're the weakest when the muscle is the strongest. So really, it's kind of getting through that to kind of strengthen a muscle tissue will really kind of help with that. But anyway, so their pain threshold is lower, so now they're in this hypersensitive state where they're constantly having to feel like they're getting away from this because what was before a mild itch is now a pain or a sting. How do we know this? If you guys know this guy, Adrian Lowe, does a lot of work in this stuff. So one of the things he talks about is persistent type pain is poorly localized. People, if you point it out one time, it's going to be different the next time. And that's not to say that it's in their head or it's just the way that they're mapping it out. So he does some grid patterning stuff. I've kind of changed his grid patterning stuff up a little bit. So he'll ask you to tell me which number I'm pushing on. I kind of like the 0 to 10 pain scale. So what I'll do is I'll do a grid pattern and I'll push on stuff on a patient's, let's say it's their back or their neck. On a scale from 0 to 10, how bad does this hurt? And it'll be a 10 to start off with. And then we'll go around that circle a few times, pushing different spots, getting different pain readings. And then by the third or fourth time, by the time we get back to where that 10 was, it's pretty common to have the patient say 75% less than a 10. So they'll be down to a 1 or a 2. And I think that's important to show patients too, is not that it's in your head, but that it's more complicated than just being something physically wrong with you. So just showing them that, hey, this is what I think is going on, and this is why I think it's going on. The other thing that I've started to use a lot is right-left discrimination. In people with persistent pain, it's very poor. So I think it's like if you show patients grid cards, they should get about 75, or I'm sorry, right and left body parts. They should get about 75% correct, and they should do it in about 1.5 seconds per question for the upper extremity. When we get people with persistent pain, it is far from that. They'll get like 50% correct, and they'll do it in like 5 seconds per question. They're not good at it, and that's when I kind of explain that, like, hey, there's a miscommunication between your brain and the rest of your body, um, and it's something that we can take care of. It's something that we can train, but we just have to change up what you've been doing, and go a little different route. One of the other interesting pieces is their perception of the body part is usually about 10% larger. I kind of struggle with this too, but I've started doing this even with people that have had shoulder pain for long periods of time. I'll have them draw your right shoulder, and then I'll have them draw their right shoulder, and then we'll go on for 5-10 minutes, and then, hey, draw your left shoulder, and it's 10-20% larger just about every time in the painful extremity. So there's something going on that's pretty interesting with this stuff. So if you guys get a chance, Adrian Lowe's stuff is super interesting. I think it's Too Hot to Handle is what the course is called, but really good stuff. So this is another way I explain kind of what's going on in persistent pain to some of my patients. So this is a homunculus. I'm sure you guys have seen this before, but we have areas. This is our cortex, so just a map of our cortex, kind of. This is obviously not what it looks like, but anyway, there's parts of our body that should be very sensitive. So if you look at your hand, it's represented by a very large part there. So it should be very, very sensitive. Same thing with your nose, eyes, lips, tongue, things like that. But if you look at your shoulder here, it should be pretty small. It's represented by a small chunk. It's not that big. What happens in people with persistent type pain is we get this smudge. So that smudge will kind of kick that into it being a bigger shape. So it'll look more like your hand than it does your shoulder. So obviously, if you're mapping out that much of it, it's way more sensitive. So we got to get it back to looking like this. So how do we treat it? We have to desensitize the system. That's one of the most important things is kind of getting these patients to kind of calm down. Sometimes I'll talk about patients about sympathetic versus parasympathetic nervous system. The feeling that you're constantly being chased by a lion is not a healthy way to go through life. So I think that this takes a healthcare team rather than just us. I would say a good 25 to 30% of my patients get a referral for some psychological assessment stuff too, because I think that is so important. We are not experts in that. So we need to have people in our team that are experts in that. So using some biofeedback type things to get them to kind of desensitize as well and tell their body, hey, you can relax. The other thing I always do is I change the conversation, break the cycle. I see this a lot in patients with low back pain. I know I'm kind of getting off topic from TMD stuff here, but it's the same story here. We're going to talk about, well, I've got a disc herniation, or I've got this, I've got arthritis. Knee patients say, I've got bone on bone. I think the more we start to learn about this stuff is the more we realize that our imaging is misleading. So looking at that study where they looked at people with, they MRI'd tons of healthy people, and tons of them had disc herniations with no pain at all. Tons of them had bone on bone osteoarthritis with no pain at all. So we know it's not a great indicator. So we have to change that conversation because we know that your brain is in control of all pain. So we change the conversation, get them kind of off of that. I usually educate on things like that. Sometimes it takes quite a few times to just educate and tell them, like, hey, I know your x-ray looked like this, but that doesn't mean that you're destined to have pain for the rest of your life. Or I know your MRI looked like this, but that doesn't mean you're going to have pain for the rest of your life. So getting them away from that kind of mentality that's not helpful. Grid patterning, I do a lot of grid patterning stuff on patients. I kind of told you guys how I adapted that. Exposure to stimulus, I think, is important too. So that's where I get people to talk about, well, it's painful to eat certain foods. So I'll kind of slowly work them back into some of those foods to get them more exposed to that type of stimulus. And then just in general, movement and exercise is so important in persistent pain. Once again, we know as muscles are stronger, nociceptors are weaker. So the more we can get patients to move and exercise is important. So just about every one of my patients that comes in with persistent type pain gets some sort of cardiovascular exercise routine that they're supposed to do at home. And when they do it, you'll see a difference. It really does make a difference. There's a lot of research to back that up too. Retraining the brain. So this is something that Adrian Lowe talks a lot about. So we work on that right-left discrimination stuff a lot. So flashcards. I usually have patients download the app on their phone. I use one called Orientate Free, which I think is really, really good. So that's a great one. Before you move on from this, though, into other things like mirror box therapy, they have to be normal in their right-left discrimination, because you can do some more harm than you can good if you work them too quick into this stuff. So I'll start with right-left discrimination. Then sometimes I'll even get magazines in the clinic, and if it's their, I don't know, their right temporomandibular joint, I'll have them go through a magazine and circle all the right temporomandibular joints on there, so they can pick those out. I think that's a good exercise. Plus, nobody reads magazines anymore anyway, so you might as well do something with them. And then finally, we get into some like mirror box type therapy things, or even just mirror therapy. Having patients look in the mirror as they move, I think, is huge for patients. If they can watch themselves move through something and be non-painful, I think that is a really good thing for patients. So we use a lot of biofeedback, so really retraining the brain. But at the end of the day, like I said, the most important thing is that we've got a good team of people that we can get these patients to. So it's definitely a team approach, with psych being a big piece of this. So, all right. And then I think we'll open it up for questions. I think we'll all get on a Zoom call after this. And then make sure you guys watch some of the videos that we're going to post up too on some of the manual therapy stuff and the ontophoresis. If you guys have any questions in the meantime too, I'll send my contact info. You guys can email me, call me. Should be pretty accessible. But hey, I want to thank you guys for allowing me to present for you. And I hope some of you get interested in temporomandibular dysfunction, because it's definitely an area of need. And really, if you're talking about private practice, it's a good way to grow a private practice as well. So, all right, thanks a lot, guys.